Welcome to the American Journal of Sports Medicine's 5th anniversary celebration. I'm Clara Azevedo, member of the Electronic Media Editorial Board of AJSM. Today, I'm interviewing the author of the 1990s top cited article of AJSM, Dr. Donald Shelburne, and discussing the study entitled Accelerated Rehabilitation After Anterior Cruciate Ligament Reconstruction. Congratulations, Dr. Shelburne. Thank you for joining us.
No problem.
Why did you perform this study?
Well, actually, I wasn't in academic practice and I didn't really perform a study. I started practice in 1982 and I did a fellowship with Bill Clancy in Madison, Wisconsin, and learned how to do patellar tendon ACL surgery. And that was kind of my niche when I started practice. I was like the best trained guy in my part of the country in ACL surgery with patellar tendon grafts. And I knew a lot of people in sports. And at the time I was seeing a lot of young people with ACL surgery. And at that time, our rehabilitation consisted of putting somebody in a cast at 30 degrees of flexion for 6 weeks, take them out of the cast and rehabilitate their knee. And that was the norm back in 1982. So I started doing what I was taught. I put people in casts, and I was getting a lot of people that are just miserable and terribly unhappy because their knee was so stiff. And it wasn't just stiff, it was painful. And it was painfully stiff, and I couldn't reverse it. And so I took a lot of teenage athletes and did this operation that I had learned on them and thought I was doing a good thing. And I end up having a lot of very, very unhappy teenage athletes that never got back to sports, and their knees were miserable. Their knees were stiff, their knees were painful, and I did it to them. And so in a way, it was my fault. And so I kept thinking, gosh, darn it, I need to do something different and try to not, we put people in casts because we thought that the bone plugs and the graft had to heal for 6 weeks, just like a fracture. So we treated grafts like broken bones back then. So we have a bone, tendon, bone, patellar tendon, ACL. We put them in the femoral and tibial tunnels, and those pieces of bone supposedly had to heal. So we put them in a cast for 6 weeks. That was the accepted procedure. And I did that like I was taught. And unbeknownst to me, I was causing a heck of a lot more problems than I was actually solving. And at that time, I started thinking, I'm 32 years old. I just started practice, and I started thinking I need to do something different. So I said, well, maybe if I can take them out of a cast and put them in a removable splint and maybe put them in a CPM machine for an hour a day, maybe I could get away with moving their knee early without causing the bone plugs to get messed up. And I did that for a while, and I put them in a 30-degree splint. And I said, well, maybe I should try a 20-degree splint, because I'm trying to get full extension back. And I said, maybe I should try a 10-degree splint. And at that time, I was telling people what I was doing. They kept saying, you're crazy. Don't you know you're going to mess up the graft? You're going to cause a problem. You're going to have a problem. And so it's 1985. And at that point, I'm thinking, I really need to make sure I'm not causing something bad, because I'm 35 years old at the time. I had a reputation of being a new kid on the block, blah, whatever. So I hired a medical student to work for me in one summer. And I said, I need to find out if these people are really listening to me, because I'm doing some radical things in rehabilitation. And if these patients of mine are not listening to me and they're causing a problem, then I'm going to look like an idiot. So I hired a medical student in the summer, and he came to me and he goes, Dr. Shelburne, I've been talking to all these first 3 years of your patients. Are the patients supposed to be wearing their splint all the time? I said, oh yeah, 23 hours a day, just take it out 1 hour a day, put their leg in a CPM machine. He goes, well, nobody I talk to sleeps in their splint. I said, what? And he said, nobody I talk to sleeps in their splint. They all take it off to go to bed. Oh my God, I didn't realize that. I said, I need to find out who those people are. And he goes, oh, also, are people supposed to be on crutches? I said, of course, 6 weeks on crutches, 6 weeks in the splint. Why? And he goes, nobody I talk to uses crutches inside the house. I said, what? These patients are all telling me they're using their crutches, they're sleeping in their splint. He goes, well, they're lying to you. And I said, well, I need to find out who these people are, because my reputation's on the line. If I'm messing them up, I need to know. And it turns out that the people that weren't listening to me have better results than the people that listen to me. And I kept thinking, why am I causing these problems when patients that are doing things on their own are doing better than what I'm trying to tell them to do? So at that point, I'm balancing between stiff knees and failed ACLs. And so I'm trying to go back and forth. Okay, what's worse, having a stiff knee or having a failed ACL? And at that time, I decided people that have stiff knees are miserable. People that had failed ACLs, I can always redo it and try it again. And so I was opting for, well, maybe I should push them to not ever get stiff knees. And if I push them too hard and the graft fails, I can always redo that and correct it. And a stiff knee, I can't undo. And so I kept checking my stability, checking my outcomes, checking things. And by 1989, I found that people can get full extension back, people can get flexion back. They don't need to wear a splint. They don't need to use crutches, and I'm not breaking the graft. I kept thinking, darn it, I didn't know that. I'm causing all these problems because I had no clue, and nobody out there had any clue. What is too fast for pushing the knee motion, pushing the weight bearing, pushing the activity? When do you break the graft if you push it too hard? And at that point, I found out that we couldn't push the graft, a patellar tendon graft. We couldn't push the graft hard enough to break it. And at that point, it was like a hallelujah moment. I didn't realize. And so that's why it became a study. It wasn't really a study. It was just an experimentation of over the years and over the years and over the years. And I got to the point in 1990, I'm starting to tell people, I said, you know, I do patellar tendon grafts, and getting motion back is important. Getting off crutches is important. Not wearing a splint is important. Not wearing a brace is important. But at what point do we risk it? And at that point, I said, you know, with patellar tendon grafts, I have not found a point that I can push people hard enough to break the graft. And friends of mine said, wow, you need to let people know about that. And so that's why it became a study, you know, a study in a way. It was a study all along, but it wasn't intended to be a study because I wasn't in academic medicine. I was just a young guy trying to pursue, you know, becoming a sports medicine specialist. And so I wrote that article back in 1990 because the rest of the world was still putting people in 30-degree splints and casts and crutches and non-weight bearing. And at that point, it was kind of a landmark discovery because nobody had the volume or the, I guess, patient follow-up like I did to risk doing things differently. And so that was a eye-opener for me and for most people that with patellar tendon grafts, you didn't have to be as careful as we thought we had to. And it was really kind of a neat thing in 1990. And then from then on, you know, we've been fine-tuning and fine-tuning and fine-tuning, but that was a really, really eye-opener for me in the world.
Great. So that, I imagine, brings us to the answer to the question, what is the biggest impact your paper has made on the field of sports medicine?
If you're doing patellar tendon grafts, you know, and I think that's the problem, is that that trend has been going the other way a bit. But with patellar tendon grafts, what it has helped me and other people that I know that do patellar tendon grafts, getting motion back is critical to success as much as having a stable knee. I deal with young athletes a lot, and I could not believe how young athletes that had stable knees but didn't have perfect motion were totally upset with their outcomes. And I kept thinking, yeah, but your knee's nice and stable. But they said, it doesn't feel right, doesn't feel right, doesn't feel right. I said, yeah, but your knee's stable. It doesn't feel right, doesn't feel right. And so it emphasized to me that stability that we were trying to focus on was one factor in their happiness. Nobody that had loss of motion was happy with their knee. And I never knew that. I never realized that because in the past, loss of motion in joints was not a big deal. You had shoulder surgery, you had ankle surgery, you had other surgery. If you didn't get perfect motion back, it's not a big deal. So why are these athletes so unhappy not having perfect knee motion? I mean, that was the second eye opener for me, is that the knee joint is a totally different joint than every other joint because these people with knee problems were totally dissatisfied with a stable knee that did not have perfect motion. And so that's been the focus of my practice for the last 30 years.
Right. So what would you do differently now? Or what did you wish you knew back then?
Oh, geez. That getting the motion back is probably, it's not really more important. Having a good result is important, but having a good result stability wise is only good if you have normal motion. And so people that think stability at the expense of motion is acceptable, not really. The two things, getting stability, the nice thing with patellar tendon grafts, I've been doing that exclusively for 39 years now. Patellar tendon grafts are very, very predictable as far as obtaining stability. We don't have unknown failures. People don't come in with a 4-week-old ACL reconstruction with patellar tendon grafts and have it fail. And so it's nice if we have a reproducible surgery. And the second goal then is that you have to get normal motion back. Well, we can do that as fast as we possibly can. So our goal is to get full extension back preoperatively, the night of surgery, the day after surgery, the week after surgery. Full extension has to be gotten back pre-op and immediately post-op, because the graft has to fit in the knots perfectly, and it only does that in full extension. The second thing we have to do then is get full flexion back. Well, again, people were afraid to get full flexion back in the past, and now we try to get full flexion back by 4 weeks. And full extension back immediately, full flexion back by 4 weeks, and then we try to get the donor site strength back. And what we shifted to in 1994, since patellar tendon grafts are so good, and we had revision patients back in the 80s that had opposite knee patellar tendon grafts for their revisions, taking the graft from the opposite knee actually allowed us to improve the outcomes even more. So now the extension is there, the stability is there, the flexion is there, the donor site strength is there because we take the graft from the other knee. And we've made ACL surgery a tremendously predictable, reproducible outcome compared to what we did back in the day.
Yes. What suggestions would you have for new authors from your experience as the most highly cited author?
One of the biggest problems with ACL surgery is that most patients don't have their final outcome for quite a while. And so most surgeons that take care of patients with ACL surgery rarely see their patients when they've finally gotten back to their ultimate level of activity. And so surgeons don't have a good way of judging their outcomes by looking at patients at 2 weeks and 2 months, because they're never back to normal by then. And we feel like that, well, if they're a little bit stiff, they don't have their motion back, it'll come back, it'll come back. We know that with other joints. Frozen shoulders are a disability, but everybody knows that frozen shoulders go away eventually. Well, stiff knees are a disability, and you see somebody at 2 months with a stiff knee, and that's the last time you see them, but they're stable. You pat them on the back and say, you're going to be okay. Well, it turns out when you follow patients 2 years and 5 years and 10 years, they're not okay. And so ACL surgery, unlike taking your tonsils out or taking your appendix out, ACL surgery is an evolutionary thing. You cannot look at somebody short term and have any idea what's going to happen to them returning to sports. And then you have no idea what's going to happen to their knee in 10 and 20 years. So the only way to know if you're going to have a good outcome in 10 or 20 years is getting that outcome as soon as you can after surgery. And that's why we do what we do. By 2 months post-op, all of our patients have full extension, full flexion, stable knees, and good strength. And then I know that short-term they have a good outcome. And when I see them in 20 years, they're going to have a good outcome. And that's something that most people don't know and don't understand.
Thank you, Dr. Shelburne. So that's a wrap, and happy 50th AJSM.
Thank you.